I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. Let us start with a few slides about microbiology and epidemiology. Histoplasma capsulatum is a dimorphic fungus. This is how it looks like in the environment, and this is how it looks like in the human host. The passage from mycelial to yeast-like form is triggered by a rise in temperature in vitro from 25 to 37 degrees. This map shows the global distribution of histoplasmosis. Although there is an endemic focus of histoplasmosis in Italy, the cases that have come to our attention were all imported from North or South America, Africa, or Asia. In the United States, the prevalence of histoplasmosis is particularly elevated in the Mississippi and Ohio valleys. An estimated 40 million Americans are infected, with some 500,000 new cases per year. The reservoir is humid earth filled with organic matter, particularly pigeon and other bird feces, and in caves, bat guano. The large epidemics in the Mississippi and Ohio valleys produce mostly asymptomatic cases or symptoms of upper respiratory tract infection. In a very small percentage of immunocompetent people, there is pulmonary disease resembling tuberculosis, fibrosing mediastinitis, erythema nodosum, and arthritis. The clinical manifestations in AIDS-associated histoplasmosis are very different. Practically all patients present with disseminated infections. Fever, pancytopenia, enlargement of liver and spleen, pneumonia, and ulcers in the GI tract. There may be unusual manifestations such as CNS involvement, mouth ulcers, skin lesions, and pancreatitis and pericarditis. Patients have advanced immune deficiency with many other opportunistic infections because of the very low CD4 count. The frequency of histoplasmosis differs enormously depending on the patient's origin. In Switzerland, among 7,642 AIDS-defining illnesses, histoplasmosis was diagnosed only 5 times. In contrast, in Indianapolis, it was the inaugural AIDS-defining infection in 1/3 of cases, and in Guatemala in 11.4% of cases. In French Guiana, 156 cases of disseminated histoplasmosis occurred in 1,404 HIV patients followed during 5 years. We'll continue with some case studies. Case 1 was a 46-year-old man from South America. His last CD4 count was 413, but dated from 5 years previously. He was never on heart. He returned home in December 2002 to help his parents clean out a basement. On return to Switzerland, he suffered from fever, lost 17 kilograms of weight, coughed, and had diarrhea. At admission on March 28, 2003, he had confusion and respiratory distress, suspected Kaposi's sarcoma lesions on thighs, cheek, and left calf. oral candidiasis and oral caposarcoma, enlargement of liver and spleen. He was tachypneic at 40 per minute. His PO2 was 7.2, that's 56 millimeters of mercury. The PCO2 1.5, the basic says -15, the pH 7.36. This was interpreted as a compensated metabolic acidosis. The LDH was 2012, the transaminase is 5 times upper limit of normal, and he had renal failure with a creatinine of 1065 micromoles per liter. That's approximately 8 milligrams per 100 milliliters. The chest X-ray showed diffuse pulmonary infiltrates, which were also visible on the CT scan. This image is typical for disseminated histoplasmosis and has been compared to a snowstorm. Intracytoplasmic inclusions were seen in his white blood cells. Blood cultures yielded Histoplasma capsulatum, and he had a CD4 count of 14 with a viremia above 500,000. Intracytoplasmic inclusions were visible in the blood smear and the bone marrow aspirate on lower right. These inclusions were also seen in the bronchoalveolar lavage with the fungiflor stain. Note that the picture is in focus, and the Gram stain. Another view of the histoplasma yeast form seen in the bronchoalveolar lavage. In addition to all his other problems, the patient had a massive melena with hypotension and a fall in hematocrit of 10 points on the second hospital day, necessitating 9 units of blood. Gastroscopy showed a gastric ulcer, which had ceased to bleed, however. Histoplasma capsulatum was found by biopsy and culture. The renal failure was treated with 72 hours of hemofiltration, the respiratory failure with CPAP and oxygen without intubation, the histoplasmosis with liposomal amphotericin, later with itraconazole, and the HIV infection by efavirenz, abacavir, and 3-TC. The outcome was rapidly favorable, but the patient complained of loss of vision in his right eye. The patient had a CD4 count of only 14, exposing him to other opportunistic infections in addition to histoplasmosis. His loss of vision was due to concomitant cytomegalovirus retinitis. With prompt ganciclovir treatment, the patient recovered most of his visual acuity. In North and South America, Histoplasma capsulatum var capsulatum, HCC, predominates, whereas in Africa it is Histoplasma capsulatum var duboisiae. The disease caused by these two variants does not differ much, except that skin involvement is said to be more frequent in Africa. Skin lesions in histoplasmosis may include nodules, papules, plaques, ulcers, vesicles, pustules, and abscesses. As already mentioned, lesions in the GI tract may occur from the mouth to the anus. Mouth lesions are painful with ulcerations and hypertrophic areas suggesting malignancy. Skin lesions in an HIV-infected patient from Zurich with positive blood cultures for H. capsulatum. A skin biopsy shows granulomas with intracellular inclusions, which are particularly visible with a PAS coloration. This patient was from Zimbabwe. On the left, typical umbilicated lesions. On the right, oral lesions. The diagnosis was established by biopsy. Two examples of destructive lesions suggesting neoplasia in patients with AIDS and disseminated histoplasmosis from Argentina. The last case in this series illustrates a complication of histoplasmosis, namely the Hemophagocytic lymphohistiocytosis HLH syndrome. It was a 50-year-old woman originally from Ivory Coast, but having lived in Switzerland for 20 years. In August of 2022, she presented with weight loss, pancytopenia, and persistent fever for 10 days, despite empirical antibiotic treatment over the last 3 days. She was found to be HIV positive with a viremia of more than 100,000 and only 23 CD4 cells. Her hemoglobin was 102, her white blood count 1.6, and she had evidence for liver involvement with elevated transaminases and LDH. Initial explorations were non-conclusive, with negative PCRs for EBV, CMV, HHV8, SARS-CoV-2, and a negative assay for cryptococcal antigen. The blood cultures for bacteria were negative after 72 hours and still pending for fungi and mycobacteria. The cerebral MRI and the fundoscopy were also negative. The only positive exam was an abdominal echogram showing retroperitoneal and intra-abdominal lymphadenopathy. The patient was started on HART on the 21st of August 2022. Here is a copy of the patient's fever chart during the first week in hospital. Note the extremely high ferritin levels. Based on the St. Antoine score, the probability of HLH was 74%. 20 milligrams of dexamethasone per day caused a temporary reprieve. Because the fever relapsed while the patient was on dexamethasone, the treatment of hemophagocytic lymphohistiocytosis was switched to etoposide on August 28th. In adults, HLH is usually triggered by some other condition. In persons living with HIV, these could be viral infections like EBV, CMV, or Kaposi-sarcoma herpes virus, but in our patient, gene amplification for these pathogens was negative. Tuberculosis is a possibility, but again, gene amplification was negative. The same was true for Leishmania and malaria. There was no evidence of Hodgkin's lymphoma. Finally, tests to detect Aspergillus species, namely beta-D-glucan and galactomannan, were strongly positive. After 1 week in hospital, we have a diagnosis of advanced HIV infection with probable hemophagocytic lymphohistiocytosis, strongly positive assays for beta-D-glucan and galactomannan without lesions evocating Aspergillus, and evidence of liver disease with elevated transaminases, gamma-GT and alkaline phosphatase, indications for a transjugular liver biopsy. The liver biopsy showed multiple intracytoplasmic inclusions in macrophages. Can you spot them? Large spectral gene amplification on the liver biopsy was positive for Histoplasma capsulatum. Finally, blood cultures taken on day 1 were also positive on day 10, yielding histoplasma. Liposomal amphotericin B, 3 mg per kilogram per day, were given for 2 weeks, followed by itraconazole, 200 mg per day for 6 months. The patient returned home after a 5-week hospital stay with a negative urinary assay for histoplasma, a normal blood count, ferritin at 722, and 33 HIV copies per ml. The differential diagnosis includes other microorganisms visible in bone marrow smears, skin biopsies, or bronchoalveolar fluid such as leishmaniasis, disseminated toxoplasmosis, pneumocystis jirovecii, microsporidiasis. This is more fully treated in the video on leishmaniasis. The differential diagnosis of umbilicated skin lesions in patients living with HIV is molluscum contagiosum, cryptococcosis, and leishmaniasis. Histoplasmosis take-home lessons. Assays for beta-D-glucan and galactomannan are not specific for Aspergillus, but can be positive with other fungi. Histoplasma cultures can take weeks to become positive. Regarding treatment, itraconazole solution is better absorbed than tablets. Voriconazole is also effective and has better brain penetration. Fluconazole and echinocandins are not recommended. Among newer agents, posaconazole has very low inhibitory concentrations, and urinary antigen is useful for monitoring. Thank you for watching, and thanks in particular to Dr. Stefano Musumeci for contributing the case of HLH and histoplasmosis. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.